hope is that imaging and other technologies to identify those most aggressive patients will be here shortly, and we'll be able to integrate that into care.
So speaking of imaging, so Ash, tell us your experience now with some of the newer imaging techniques. Specifically, you know, we concentrate our imaging efforts right now clearly on the patients in the CRPC setting, but your institution has done some trials looking at advanced imaging techniques, even in this in this hormone naive setting, early setting. So,
yeah,
update us a little bit about that.
I think that there has been a lot of progress in this field, and it's coming more and more to sort of the national availability for a lot of providers. Some of what you're referring to was derived from Marty Pomper's work, and he was looking at prostate-specific membrane antigen. And he found that small urea-based molecules could have a high affinity for them, labeled them. There's an F18 labeled version that some people refer to as the DCPYL. There's another gadolinium labeled version that's been used a lot in Australia and also in Europe, now is in the US as well. And we've been looking mainly at the F18 labeled versions at our institution. And we've done a couple trials that I think have been quite remarkable. One was, and these are pilot level studies and then clinical utility studies, but one was a trial of patients after definitive treatment who had biochemical recurrence, and we wanted to see if we imaged them at low PSAs, below 1, how many times would we see a lesion, and then we would treat them with whatever type of therapy we wanted and re-image them to get a proxy of it actually being a true positive or true negative.
And in all those patients, had they had preoperative scans,
traditional
bone scan CT was negative?
That were negative.
Okay.
And what we found, and to bring up Dr. Gassira's point too, what we found was first, 70% of the patients, and I was a little bit shocked, would have some kind of detectable lesion, usually in a lymph node, usually, although some bone lesions were seen. And to your point, we also did another trial which we took high-risk patients, NCCN high risk or very high risk, preoperatively, and scanned them before surgery. And about 10% of those patients would have even M1A prostate cancer prior to surgery. And so what it tells us is two things. In the biochemical recurrence setting, what you are looking for after definitive quote-unquote treatment is your recurrence localized or not? I truly believe there's a difference even in the man who has quote-unquote metastatic disease. You know, are they really metastatic or just N1 with pelvic nodes versus M1A? And there's certainly a difference between M1A and M1B as well. And the imaging is really going to show us that. The secondary question or part of it is we've talked about identifying which men you need to treat, but I think we have to move towards looking at treatments that are really cytotoxic, or ablative. And we're going to talk maybe later in the session about some of the bone-directed therapies, et cetera. But also with stereotactic radiation, you can start to spot weld these lesions. We don't really have great evidence that that's going to make a difference, whether treating a micrometastasis that's really micrometastasis in the blood is different than treating a colony of metastatic cells that are sitting in a bone or in a lymph node in a microenvironment. Is there going to be any difference there? But I agree with you. The FDA has approved the Blue Earth compound, which is mainly an Emory-developed compound. And right now in clinical utility trials is these PET PSMA-based molecules. They appear to be more sensitive than even choline, probably around the same sensitivity in my impression for bone as fluoride, more specific than those compounds, and they will start to revolutionize our ability to detect what's going on. And I don't know whether that's going to change outcomes for the patients or not yet.
All right, I completely agree that the new imaging techniques are going to be widely used, but it's going to create a lot of questions because they could be so sensitive. Then what's the clinical meaning of all that? Especially because many of these patients probably would have traditionally had negative bone scan CTs. Now we're talking about, in terms of staging, potentially identifying patients, which I think we all are moving towards, is the therapeutic management of oligometastatic disease, how to manage the primary.